Good morning. We're presented with a 3-month-old female with multiple cutaneous hemangiomas. An abdominal ultrasound was ordered, demonstrating numerous liver masses, hypoechoic and as large as 1.5 centimeters. They're well circumscribed and with color flow demonstrate hyperemia, with both arterial and venous flow increased in these lesions. The adjacent liver parenchyma is normal. Cutaneous hemangiomas are common. 4% of the population will have them, with an increased incidence in Caucasians and females, and in particular the premature. They have a typical life cycle, growing for 9 to 12 months and involuting over the next few years. Infantile hemangiomas express the GLUT1 gene. Visceral lesions are associated with multiple cutaneous lesions, and a Spanish study demonstrated that 16% of 151 infants with cutaneous lesions had hepatic hemangiomas. All of these infants had 5 or more cutaneous lesions, and most had solitary infantile hepatic hemangioma. The classification of infantile hepatic hemangioma has changed in recent years. They are divided into focal, multifocal, and diffuse disease. An archaic term, hemangioendothelioma, can be confused with the malignant lesion epithelioid hemangioendothelioma, which is not necessarily a liver lesion. Focal lesions are usually asymptomatic, frequently found prenatally, and rapidly involute. They do not express the GLUT1A gene. Rarely are these associated with high-flow states. Here, an infant with an incidentally found liver lesion underwent an MRI. This T2 sequence demonstrates a well-circumscribed mass of approximately 6 centimeters. This lesion involuted over 1 year without any therapy. Multifocal lesions are often asymptomatic. Lesions are usually uniform in imaging characteristics, demonstrate centripetal filling on MRI or CT scan, and are often associated with shunting and a noticeable caliber change in the abdominal aorta below the celiac trunk. High output failure may occur and is seen in up to 8% of these infants. These lesions are GLUT1 positive. Here, the infant that we present at the beginning of this talk has multiple small, well-circumscribed lesions, bright on FSE T2 and single-shot T2 imaging. These lesions filled centripetally. Here, the post-gadolinium T1 sequence. Notice one of the cutaneous lesions here. The numerous masses, relatively uniform in imaging characteristics throughout the liver. And notice here a good example of the centripetal filling. These patients also demonstrate the caliber change. Here notice below the celiac axis, the very small abdominal aorta. Diffuse lesions can have total replacement of liver parenchyma by the innumerable lesions. These are frequently very symptomatic infants, often in heart failure at the time of presentation, though interestingly enough, not usually high output failure. The diffuse lesions enlarge the liver and may impede IVC flow back to the heart and compromise respiration. These are also associated with severe hypothyroidism. Here an example of a child with diffuse lesions, and notice how large his liver is. This diffuse involvement of the liver was life-threatening, and this child was in the ICU for several months, requiring intensive therapy. Imaging options in the 21st century include ultrasound and MRI. CT is usually reserved for those infants too sick to obtain an MRI who do need further imaging. CT is not routinely performed. Treatment today includes low-dose propranolol. It's very effective, and doses as low as 0.5 milligram per kilogram can be curative over several weeks. Steroids are still used. Vincristine is used in severe cases, as is interferon and embolization. Rarely is transplant necessary. The differential diagnosis of infant liver masses is divided into multiple and solitary. This is not an exhaustive list, but certainly includes the most common masses. Multiple lesions are typically neuroblastoma. Solitary lesions can be hepatoblastoma, mesenchymal hamartoma, and angiosarcoma. Here, an example of a hepatoblastoma. Notice that this lesion on T1 weighted imaging includes some bright T1 signal. In addition, small calcifications were noted on ultrasound. This likely reflects hemorrhage and subsequent calcification into this lesion. Mesenchymal hamartomas are usually more heterogeneous than hemangiomas. Notice the cystic spaces in this patient. Here is a brief bibliography for further reference. Thank you.